Hello everyone, it's Richard here, and today's in service will be covering underwater seal drains. Not something that is common on B22, but as like most things that we see here in B22, we often see items that aren't really the specialty here, and they seem to come in waves. We had a few patients present with these, so I just thought I would take the chance to go over the theory of this intervention itself, why they will be put in, and some nursing strategies that you will need to know when you look after these patients. So let's get into it. So before we talk about the drain itself, we are going to talk about some of the conditions that you would see for a patient requiring a chest drain. So the first one is a pneumothorax. So a pneumothorax is when air is released into the pleural space and it causes a collapsed lung, and the chest drain is put into that space there to drain out the air into the chest tube itself. So if you think of your lungs like two sheets of glass sitting on top of each other, and in between the plates of glass there is a thin layer of water. That water is like the pleural space there. So that space there does not normally have air. So if you have a patient that presents with a condition like a rib fractures or a fractured clavicle, that space, there could be a puncture that can cause air to leak into that pleural space there. So if you think the bottom layer of the glass is the lungs, and that is now leaking air into that space that's meant to act as a lubricant, and essentially it's pumping air into there, so it's inflating like a balloon to the point where now there's air pushing against the lung itself, restricting its inflation. So the chest drain goes into this sort of black space there, and then when the drain is put in properly, you will see it bubbling in the water chamber. So essentially, patients with a pneumothorax, if they have a chest drain, you should see bubbling, and with the next condition, you shouldn't see any bubbling for the patient in the chest drain. So the next condition that we often see patients requiring a chest drain for is a pleural effusion. So a pleural effusion is the abnormal accumulation of fluid in the pleural space between the lungs and the chest wall. So again, going back to my pretty poor analogy of the two plates of glass and the water in between, that layer of water, in total, there should only be probably about 10 to 15 mils. So these patients, for whatever reason, when they have a pleural effusion, that fluid accumulates. And some of the patients that we've seen in B22 requiring a chest drain, the fluid out, they have about 2 to 3 liters of fluid there. So you can imagine a space that should only have about 10 to 15 mils, having 3 liters, that really restricts the inflation of the lungs. And some of the reasons why a patient might be having a pleural effusion is infection. If they have a background of cancer, the cancer can cause accumulation of the cells that create the pleural effusion in there. And so we need to make sure that the lungs are expanding. So we need the chest drain to go in to drain out this fluid. So if you are having a patient with a chest drain with a background of pleural effusion, you need to be aware of the quite specific plans that the team might have regarding the fluid output. They might write an order like drain 500 mils, clamp the drain for 6 hours, and then release the clamp. We don't want to be draining the fluid too quickly as well, but you should see the patient comfort increase as soon as this drain is put in, because they will be struggling to breathe as the lungs can't expand and their saturation should come up. Oftentimes, after the drain has been put in with a pleural effusion, they will send off quite a number of 50 ml syringes full of this fluid off to pathology to see what might be causing this accumulation of fluid. So now we'll talk about the chest drain itself. So this image is probably the closest image I could get to what the chest drains that we get here in Campbelltown Hospital. So the chest drain allows air and fluid to leave the pleural space and prevents it from re-entering the lungs. The tube exits the chest and connects to a drain unit with an underwater seal, the water chamber. So the bottom left corner of this image, there's that little gray space inside the black. That is where the water goes. So if you can look at this image up the top, it says water seal chamber. Oh no, sorry. It says to suction. There's a little tube up there. So when you open up the packet for a chest drain, you'll see they'll come with like a little plastic bottle of water. You take off the tap of that, pour the water into the suction part, and allow it to fill into the water chamber there. You must never ever connect a chest tube to a patient unless there is water in that chamber there. And if for whatever reason the doctors wanted the patient to be on low wall suction, the wall suction would connect to that port where you pour the fluid in. There's only one place the water can go in, and there's only one place the suction can connect to. So they've tried to make these things as idiot-proof as possible. So with the 3 chambers on the right, there's one chamber starts from 0 and it goes all the way up to 200, and basically that is where the fluid will pour into from the patient's chest cavity. And we need to be aware when we take over care where that fluid level is and be mindful of the output as it drains, so we can clamp it as ordered by the team, and being mindful as it approaches the top of the 3rd chamber that we want to be organizing someone to get a new chest drain, or you should be organizing to be perfectly honest. And if you aren't accredited to get the chamber changed, you should organizing myself or someone more appropriate who is accredited to change the chest drain. Suction. So these chest drains also come with an automated dial on there that will cause suction to occur to remove the fluid from the pleural space. So the suction essentially acts like a little straw trying to draw out the fluid constantly from the patient's chest cavity there. So the suction helps remove air or fluid from the pleural space, allowing the lung to re-expand. So the thing to really remember for this is when you take over care, this dial should be set at 20. That is the standard measurement that patients should be set to with the chest drainage. And if there's any change required, the team should be documenting what they put it on. So just be mindful when you open up the chest drain packet, you should see it automatically set on 20. And when you take over care from patient, make sure that you see that it is set at 20 as well. Insertion principles. So this image in the background there, this is essentially how they insert the chest drain when they go to A61. So they're inserted, sorry, I'll start from the first bullet point, inserted in interventional radiology or by the respiratory team in the A61 procedure room. A consent is required. The drain must be sutured and covered with a sterile dressing. The patient needs to have a chest x-ray within an hour to confirm the position, and we need to have clamps present at the bedside in case the drain itself has become dislodged or disconnected from the patient's body, and observations are to be documented in iView. So I probably should have put an image of the metal clamps on this presentation, but essentially the clamps will act as our safety mechanism if for whatever reason, if the patient gets up too quickly or the drain becomes ripped and disconnected, we need to make sure that we're inserting the clamp close to the insertion site near the patient's body so that air isn't just leaking out into the atmosphere or preventing any items going into the patient as well. The drain, when it comes out from the patient's skin, will be connected to a 3-way tap that you can use when you need to slow down the drainage or clamp it as well. And hopefully there's an image, I'm pretty sure on the next slide that will demonstrate that. There it is. So you can see coming out of the patient's skin is the tube, and that leads down to our 3-way tap there. And then after the 3-way tap, that part of the tube will lead down to the chest drain itself. So this dressing, you can see there's IV3000s on it, and that sort of Mepilex or ZediFit type dressing is just to prevent the 3-way tap resting on the patient's skin and causing a potential pressure area. So in terms of nursing for our patients, we need to make sure that they're in a sort of semi-phallus position, making sure you're checking the skin integrity, keep the underwater seal drain upright and below chest level, so make sure the patients aren't swinging the chest drain over their head when they're going for a walk. Keep the metal clamps nearby. Monitor for any excessive drainage that is leaking out from the insertion side. Make sure the chest x-ray has been attended. Never milk the drain. So lifting the tube itself, which is quite thick for fluid to pour into the chest drain, that is fine, but do not try and manipulate the fluid to come out of the drain itself. And typically, we should never be flushing drains that have been inserted for a pneumothorax. Although in my time in this hospital, I have seen doctors wanting that done, but make sure that is documented if they do wish for the chest drain to be flushed. Securing connections for the pleural drain. So the connections between the pleural drain and the drainage tubing should be secured with a non-stretch tape, like in this image here. It's to prevent it from being dislodged. So The left side of the image, that tube is going down towards the patient, and then the right side of the image is going towards the, sorry, I'll start again. The left side of the image is going towards the chest drain, and the right side of the image is going towards the patient. And when you're taking Novacare, make sure you're mindful of how it is secured. So we've got this brown tape, the Leukoplast on there. It's been cut into strips, strip rungs along one side of it and then on the other side, and then we have two more strips that loop around to help secure the tube to make sure it is not dislodged for whatever reason. You can imagine if a chest drain is put on the end of the bed, if a patient goes for a chest x-ray sometimes, and with our very narrow rooms in B22, the chest drain could potentially get caught on a doorway or another bed, or air mattress what am I trying to think of? You know what I'm talking about. It could get caught on something essentially, and then it could become dislodged. We want to minimize that risk of it happening. So make sure if you do not see this tape on your patient with a chest drain that you are securing it properly to prevent any future issues. Now we're going to talk a little bit about clamping and transporting. So we only clamp if instructed by the medical or trauma team. We do allow clamping for when changing the underwater seal drain, or if there's a sudden dissection or breach from the tubing, if we need to collect samples, and before the drain is being removed. The maximum time we should be clamping is around 2 hours, unless otherwise directed, because we don't want any sort of coagulation of any fluid that's caught in there to preventing a flow of the fluid coming out in the future. When transporting our patients with a chest drain, pleural drains should not be clamped for transport. However, if the patient has reached their maximum output level that the doctors have specified, so again, going back to the example from earlier, if they want it to clamp after 500 mils, and if it's reached 500 mils and they want to clamp for 2 hours, then just maintain that order then. But in general, we shouldn't be clamping pleural drains. They need to be escorted by a trained clinician. You're a trained clinician. You're an RN. I'm educating you now. You need to go with your patient to wherever they need to go if they're being transported out of the unit. They should not be transported off-site to an external provider. So if your patient needs to go for a bone scan with a chest drain, we should be highlighting to them, hey, you know what? They've actually got a chest drain. I don't think it's a great idea for them to go in an ambulance right now. So make sure you're advocating for your patient's care. Observations. Drain observation. So we don't want the output to exceed 500 to 1,500 mils of fluid in the first hour or so. Need to monitor for any respiratory distress. We need to do our obs like anything else, monitoring for pain. Site observations as well need to be attended. And all of these underwater seal drain observations should be going on iView in terms of things like swing, bubbling, drainage volume and type, dressing connections, and in terms of how often we would do this, every 30 minutes for the first 2 hours, hourly for the next 4, and then second hourly until the drain is removed. So how do we put it in on iView? So you will go onto iView, you would find the tubes and drain section, and then you would be having to right click to add a new chest drain for your patient on there. In this example, in the image, we have a right-sided chest pleural drain. The chest suction will always be at 20. This is a standard practice unless the medical team want a different suction amount or it is on wall suction. This title can stay clear to save confusion. You can it's probably best just to sort of pause this and go down the iView chest drain image here on the left to see all the different sort of like categories you've got on there and all the sections you would need to fill in for the patient when you're caring for them. Site assessment. So you want to be looking for redness, swelling, excoriation, any signs of dislodgement. So I cannot emphasize enough with people with chest drains or any type of drains or tubes when you're taking over care of patient. I know it's annoying, especially on the night to morning handover, but you really should be looking at the insertion site. So you sort of have a baseline of what this drain looks like. So if anything does occur or when the team come around and ask any questions, you have a baseline to compare it to. You need to be monitoring for any subcutaneous emphysema. So sometimes the air may be leaking into the subcutaneous tissue and it actually feels like bubble wrap. If you observe this in your patient or you feel this, you need to be calling a clinical review straight away because it can escalate to the point where it goes up to the patient's neck and we might be causing some airway respiratory issues. Are the situs intact and are there no clots or buildup occluding in the tubing? That's what you want to be looking for. Just go over three little categories here: flushing a drain, changing a chamber, and drain removal. So when in terms of flushing a drain, flushing should only be performed by clinicians that have experience and accredited. So it's like essentially, this is like flushing a pigtail dressing. You essentially need to make sure that there's an order for it. You can flush via the three-way tap. And then if you've never attended that before, ask myself or one of the after-hour CNSs and they can help accredit, but it's really not that difficult. We're flushing to maintain patency for pleural effusions and not flushing for patients with a pneumothorax, as I stated before. Changing a chamber, so eventually if they're being put in for our patients with a pleural effusion, they probably have quite a large volume of fluid in there and we're going to need to change this drain at some point. So if you need to change it, you can ask myself. We need to make sure we're organizing for another chest drain. I believe B3 Medical have some, but also A61 keep them too. If I'm not around, we can contact someone from A61 to assist. The drain should be clamped prior to changing the chamber. It does need 2 staff in case something goes wrong, and accurate documentation must be done afterwards, like anything. Drain removal. So once the drain has ceased its bubbling, if it's in for a pneumothorax or the output has sort of tapered up over a number of days with a pleural effusion, the doctors will eventually want the drain removed. So once it has been removed, it's really not that difficult. It just comes out whilst the patient is laying in bed. It's an accreditation as well. And then after the X-ray, after the drain has been removed, our patient will require an X-ray after 2 hours to ensure that the lungs are expanding as they need to. Sorry about all the errors. It is about 9 o'clock at night, and I'm just trying to do this because it's been gnawing away at my brain to attend this. Okay, so if you have any questions, feel free to throw them into ChatGPT or I guess ask me as well, and we will try and figure it out together. That's it. Hope this was helpful in some small way, and I look forward to talking to you on the next in service. Thank you, everyone.